talk about, I'm a clinician, so I will talk about the adjuvant, mainly adjuvant approach for early stages resectable non-small cell lung cancer patients. Sorry, these are my disclosures. And what we decided today for the adjuvant approach in our resected patient is more or less based on this clinical trial and meta-analysis that you very well know. Unfortunately, if you estimate the absolute risk and benefit for 100 patients with resected non-small cell lung cancer here represented, as you can see, the benefit, the advantage coming from the chemotherapy in the adjuvant setting is represented by the relatively small gray part that you can see in the slide. So it is clear that there is still a room of improvement to ameliorate this data. There is the never-ending story about neoadjuvant versus adjuvant. So let's start from the ultimate goal of the adjuvant therapy. Obviously, the ultimate goal is the prolongation of the overall survival. And the way in which we can reach the goal is to prevent the relapse and to deal with the remaining micrometastasis. If we talk specifically about immunotherapy, maybe the role in the adjuvant setting is the target, let's say, the reinvigorate the immune response, targeting the T cell, monitoring the residual tumor cells. What about the neoadjuvant chemotherapy? Well, the ultimate goal is exactly the same, because the ultimate goal is again to ameliorate the overall survival. The way in which we can target, we can reach the ultimate goal is to downstage the disease. And talking about the immunotherapy, well, in this case, the tumor is there. So we have the neoantigen load from the presence of the intact tumor. So in this case, we can activate the T cell response. Which are the pros and cons? Well, we discussed for decades about the pros and cons of neoadjuvant versus adjuvant therapy. You know very well that one pros of the adjuvant setting could be, for instance, to avoid the delay of surgery. You know this very well. One advantage for the neoadjuvant could be that in the neoadjuvant, we know that the tolerance to chemotherapy is better. But if you have a look on these slides, you can see that these are general or generic items discussing adjuvant versus neoadjuvant. Maybe the only item that we can discuss specifically for immunotherapy is this one. So again, the tumor is there, and we can activate the immune response and to gain an early induction of immune response. Having said that the ultimate goal for adjuvant and neoadjuvant approach is the prolongation of overall survival, it's logical to say that the primary endpoint of the trial is the median overall survival. But we know very well that we need time to reach this goal, to reach mature data, and we have carefully to take into account also what the patient is doing after the adjuvant setting. So there are many issues, but the first one, I believe, that is really the time that we have to wait. Look at this table. It is clear that in the last 30 years, here you have the most important randomized clinical trial, and the time indicated here is the time between the first patient in, so the first patient recruited, and the publication or the presentation of the data. data. And you can see that the window of time is between 9 years and 13 years. I can talk about the Ithaca trial. The Ithaca trial is the trial designed at the University of Torino, where I'm working, and we wait for 13 years to have the publication, to have mature data to present. This is the reason why we have to look at further endpoint. And here you have more or less all the endpoint that we can have in a randomized clinical trial. And there are some very important endpoint in complete resected and curable patients that are the patient-reported outcome, the lung cancer symptom scale, but you can understand that these are not acceptable as a unique endpoint for regulatory agency. So you have other endpoint, and I will spend few slides about this. And in the trial that we will see together later on, there are further endpoints such as the ctDNA clearance and other ones, and we will analyze. I will talk with you about this. So the main primary endpoint here listed are the DFS, is just a wording situation, why we call DFS in the adjuvant and relapse-free survival in the neoadjuvant. And then obviously we have the complete pathological response and the measured pathological response. Here you have the definition, so the absence of any viable tumor and equal or less than 10% or of viable tumor for the measured pathological response. But let's look at the pros and cons. The most important cons is that in the reality, with DFS, we do not gain so much time, and we are not able to capture the risk and benefit mainly for subsequent treatments, and also for the pathological response and the measured pathological response, we have some contrasts that are mainly the fact that, again, for the measured pathological response, we are unable to capture what is happening after the adjuvant treatment. And for the major pathological response, let us say that there is still a lack of standardization. But I believe that step by step, we will be able to gain the standardization of the methods. What about the regulatory agency? I don't know which is the situation in your country, and you will tell me which is the situation in your country, but at least for FDA and the European regulatory agency, the DFS is accepted as primary endpoint for large phase 3 clinical trial. Before moving to the Empower 010, I would like to show you a picture about neoadjuvant and adjuvant trial. First of all, we have currently ongoing some neoadjuvant trials specifically looking at this approach, the adjuvant trial, and we will see the table, and maybe really interesting ones are those designed as perioperative trials, looking at the neoadjuvant and adjuvant trial at the same time. The list is not complete at all, but just to show you that we have small sample size and large sample size, we still have some trials ongoing. What is interesting is that we are looking at the measured pathological response, and there are very exciting results, mainly for combo treatment, so immunotherapy plus chemotherapy, but not only. This is more or less a complete list of trials in the adjuvant setting, looking at different type of drugs and different schedules. At the present time, the only one that we have in a complete way, and we will talk about this in the second part of my presentation, is the Empower 010. very recently we received a press release about the first one, the PERS trial, but obviously we are waiting for the result. I would just to underline with you that in the vast majority of the cases, the primary endpoint or the co-primary endpoint for this randomized trial is the disease-free survival. So this is the Empower 010. I know you that you know this trial, you have seen the presentation, maybe you have seen the publication, but let's look at the most important point. So it's a very large trial in terms of sample size. The randomization is 1-to-1, randomized patient who underwent a complete resection, so completely resected patient who underwent chemotherapy in the adjuvant setting 1 to 4 cycle, and then randomized to receive atezo for 16 cycles versus best supportive care. The primary endpoint are listed here, but I will spend one slide about this because it's really important, and here you have the key secondary endpoints of the trial. The stratification factor, gender, that is really important because we know that there are gender differences in lung cancer. Stage 1B versus 2 versus 3A, and we will see the principal characteristics of the patient histology, the expression of PD-L1. And who are the patient randomized? From stage 1B, but with a T equal or higher than 4 centimeters, because all the data that we have in the adjuvant setting are for that specific subgroup of patient, good performance status, lobectomy or pneumonectomy, and the tissue available for the PD-L1 expression. This is the statistical design. I like this kind of design because we can gain a small amount of time, but with robust data, because it's a hierarchical design, starting from the step 1, in which the primary endpoint is DFS in those patients with an expression of PD-L1 equal or higher than 1%, and the stage from 2 to 3A. If the first step is met, the second step in the hierarchical design is the DFS, but in all randomized, same stage, all randomized, so regardless of the PD-L1 status. If positive, the step 3 is DFS in the ITT population, so including also the stage 1B. If positive, at that point, we move to the overall survival in the ITT population. This is a way to gain time, but at the same time, not losing robustness in terms of results. Let's look at the patient characteristics. You can see that in the, let's say, 3 steps, we have more than 200 patients per arm in the step 1, more than 400 in the step 2, and more or less 500 patients in the third step of the primary endpoint. 25% of the patient from Asia, the majority of the patient with non-squamous. It is important to look at the number of stage 1B. In this way, we can better consider the results. So more or less 100 patients. The current or previous smoker are more than 70% of the cases, and 55% of patients are those expressing PD-L1 at 1% or more. And we have some information about the, let's say, the most important oncogene addiction, because in any case we have as in the general population, 20 to 25% of the patient never smokers. So it is important to have this information on EGFR and ALK patients. The first step is met. So the first step, as you remind, is a patient with stage 2 to 3A with PD-L1 equal or higher than 1%. As you can see, the significant difference is there. The median DFS is not reaching the experimental arm versus 35.3 months in the best supportive care. I believe that even most importantly, you can see the difference in terms of disease-free survival rate at 24 months that is maintained when we look at 36 months. And when we analyze some subgroup of patients in terms of gender, in terms of race, in terms of ECOG performance status, there is a result maintained in this subgroup of patients. Moving to the second step, so here we have all randomized regardless of PD-L1. Again, we maintain the advantage for the immunotherapy adjuvant treatment with atezo versus best supportive care. I give you a few seconds to look at the shape of the curve and numbers, but we started at this point to see a very important results because we spent years to discuss about the validity and the robustness of PD-L1 as biomarker in the immunotherapy. And here you can see clearly the correlation between the activity and the expression of PD-L1 in resected patient. And this is there regardless of the presence or not of these oncogene addicted patients. So regardless of the presence in the analyzed subgroup of EGFR and ALK patients. So again, to remind you the hierarchical design and to underline that the significance boundary was not crossed at this DFS interim analysis in the, let's say, entire population from stage 1B to 3A. And for this reason, the testing will continue to the final analysis. So coming to the third step, as you can see, the DFS in the ITT population did not cross the significance boundary, but this is an interim analysis. And in any case, the advantage is clear also in this curve. I believe that is important also from a surgical point of view to look at some characteristics of the population. For instance, in terms of mediastinal lymph node dissection versus sampling, or the type of surgery that the patient underwent, together with other characteristics, but I do not want to enter so much into details. Just to tell you that regardless of the patient characteristics, the advantage of atezo in the adjuvant setting is clear. Obviously, we know very well, and you know better than me, that for pneumonectomy and in the bilobectomy, well, we are talking about a small subgroup of patients, but you can see that the interval confidence is very, very large. Moving to one very interesting point that is an alternative or a surrogate endpoint. It is important to see that in this trial, in a prospective way, and in 60% of the population, there was the possibility to analyze the ctDNA. And this was possible in more than 500 patients in that population in which we are more interested, that is the population from stage 2 to 3A. The treatment was well balanced in the ctDNA positive and negative, and this is important to look at the results because it's similar to the intention to treat population. The first point that we can see in this slide is that the ctDNA is a very strong prognostic factor, and the disease-free survival favoring atezo independently from the two categories, so in both ctDNA positive and negative patients, as you can see. But when we analyze the PD-L1 expression in the ctDNA positive and negative, you can see that in the positive ones, the efficacy is pretty clear in those expressing PD-L1 equal or higher to 1%. So is another piece of the puzzle moving in that direction. And again, to underline the prognostic value of ctDNA positive and negative, the same result for the negative one, where the effect is there for the patient expressing PD-L1. Now moving to the what happened after surgery, after the adjuvant setting. So looking specifically at the incidence of disease relapse, you have to think about of those patients who relapsed, and you can see that the difference is there, because here we are looking at the patient with disease relapse, and you can see that the number is smaller when we look at the Atezo R, even if obviously we do not have yet the entire number of events. We are, as a clinician, really interested about the pattern of relapse, mainly because from other previous trials there was some surprises, mainly regarding the CNS localization, while in this trial it is clear that the advantage is there for Atezo, regardless of the type of the relapse. More than this, the distribution is more or less the same, independently from the arm of the trial. And this is a deep dive in the specific site of the relapse. Let's say no measured differences. There are few slides about this issue, analyzing specifically the post treatment and the type of the relapse. I believe that in these slides the only things that we can say is again to underline the correlation between the efficacy of the Atezo in the adjuvant setting and the correlation with PD-L1 expression, because there are no other measure or important messages to draw. These are the treatment types received after the relapse. These are my last slides, no less important, just to say that at this time we cannot draw any kind of conclusion about overall survival because the data are still immature. What we can say about tolerance, the only thing that we can say, obviously, the control arm is a best supportive care. So it is clear that we are looking at a safety profile that is there for the active treatment versus the best supportive care. But the most important thing is that we cannot see, and I'm talking to leave you the time to look at the slide, we cannot see measured differences from different indication of the same drug in different line and in different setting. And I believe that the most important point is the grade 3 immunomediated adverse event and the discontinuation treatment. And these are percentages not so different from monotherapy in other setting for non-small cell lung cancer. And here you have a more detailed immunoadverse events occurring in patient treated within this IMpower 010 trial. So in conclusion, I do not want to read one by one, just to underline some important points that we have already seen. So IMpower is the first phase 3 study of cancer immunotherapy to demonstrate a DFS improvement in the adjuvant setting after platinum-based chemotherapy. And you have seen that adjuvant Atezo following a complete resection and adjuvant chemotherapy show a statistically significant benefit in those patients with PD-L1 equal or higher than 1% in stage 2-3A and in all randomized stage 2 to 3A. The safety profile of Atezo, you have seen in the last two slides, was consistent with prior experience across different indication. I believe that it's important to see that the time of relapse appear to favor atezolizumab versus best supportive care when the PD-L1 expression is higher than 1% in the stage 2 to 2 population, with minimal difference in the all randomized stage 2 to 3. There is these important results about the ctDNA results, and the fact that these represent a prognostic factor that could be used in this population. And I believe that atezo monotherapy is the new standard of care following adjuvant platinum-based chemotherapy for patients with PD-L1 equal or higher to 1%, stage 2 to 3A non-small cell lung cancer patient. And I believe that you know the publication of the trial.